are very well aware of Dr. O. John Ma, the editor of Tintinelli Textbook of Emergency Medicine. He works with Dr. Tintinelli herself. And we have Dr. Zarpak, a world leader in metadata analysis and emergency data intelligence. And we have Dr. Althani, who is the chairman of the Trauma Center in HMC Qatar, which is one of the multi-level high-quality trauma centers in the region, in the MENA region. And because of the geopolitical circumstances and the change in flights and the way things are, he couldn't make it, but he was kind enough to send us the recording. So we thought that as people are coming in, let's start with the recording, and then we will see the online lecture first, and then we will go on to the speakers. But we'll try to stay in the same time framework which we have. So can I call upon the audio-visual team to play Dr. Althani's presentation to start the session, and then we'll call upon Dr. John Ma, or we'll go reverse. We'll call Dr. Zarpak, and then we'll end with Dr. John Ma. So we'll go in an ascending order rather than a descending order. And if the audio-visual team is ready, we can play Dr. Althani's presentation. So presenting Dr. Hassan Althani, over 100 publications in literature in trauma and emergency care from HMC Qatar. Thank you.
Good afternoon, and I'd like to thank EPATH for their kind invitation for this outstanding conference, and a special thanks to the organizing committee and Professor Bashar for his kind invitation. I'm really sorry not to be in person with you guys in this conference due to the current situation in the region. And I hope that we will meet soon in the near future. I'm going to present on the utilization of extracorporeal membrane oxygenation in a trauma patient. My name is Hassan Althani. I'm from Doha, Qatar. I have nothing to disclose regarding this presentation. My objective is actually to focus on 6 important elements. I'll give a brief history of the ECMO, and then the application and indication of ECMO, but also the cardiopulmonary bypass, and I will come to the reason to include this, which is important. Then we'll give you the HMC, Hamad Medical Cooperation criteria for the ECMO in a trauma patient. We will give the local experience based on cases illustration, and also the review and the publication that we had regarding the ECMO and the trauma patient. And the cannulation team at HMC, and we will conclude eventually with this. So historically, the first cannulation and successful ECMO was done for trauma patient was now exceeding 50 years, and this is the patient on the right side of the screen with the sophisticated ECMO machine in order to support him, and he lived through. And the first unit, Isabel or Hope, was also the first successful, and this is her when she's adult to follow. So historically, ECMO has been with us for more than half a century now. So extracorporeal life lung support or extracorporeal membrane oxygenation is a therapy used to treat people with life-threatening heart and lung failure, involving the use of a machine to replace some of the function of a patient lung or heart, or both simultaneously, in order to achieve the treatment required. But it is by itself not a treatment. It is a bridge to recovery, which is a very important element in terms of how ECMO should be looked at. The strategy of ECMO is when we have a failing organism, we have to think about a bridge to decision, we have to think about a bridge to organ function or re-function, and a bridge to destination for that organ or individual. These are the three key component strategic planning for the utilization of ECMO. Based on this, if we look at this descriptive illustrated form which cover both elements, the cardiac and also the respiratory component, you can see that trauma comes very late on this refractory hypoxemia, hypercapnia, secondary to infection is the first in line, trauma and drowning and congenital or others is second. The second format for the cardiac, which is very important, you can see that the trauma come at last, and because the majority usually addressing the refractory sepsis, the cardiogenic shock, and the secondary to the myocardial infarction. The ECMO component can be a central or peripheral cannulation, and we have the veno-venous ECMO, the veno-arterial ECMO, veno-arterial ECMO, and the combination of these. It can be in hospital or out of the hospital, and addressing the time make a huge difference on the outcome. Not only mortality, but the neurological outcome for these patients. And then bridging the setting in the emergency or post-resuscitation care in terms of therapeutic hypothermia or stem cell therapy or transplant in order to facilitate for the best outcome for these patients. So this is summarizing the whole component for the extracorporeal life support for cardiopulmonary resuscitation. Our criteria at Hamad for the ECMO and the cardiopulmonary bypass in a trauma setting is having these components. It is not much different than any trauma center worldwide, whether it is in Australia, like in the Melbourne, or the shock trauma center. We just had few modifications, mainly addressing the patient with the need for intervention, especially when it comes to the patient who has